slide. You can go on, please. Hello? Oh, thank you. So, as Jessica said, I am a medical doctor, internal medicine specialist, and I come from a hospital in Portugal, and my specialty is on heart failure, in chronic heart failure, in management of heart failure at home and at day care hospital. This is the table of contents of my presentation today. So first, I'm going to talk a little bit about cardiovascular diseases and the burden of the cardiovascular diseases. Then about the biggest problem in cardiovascular diseases, that is the heart failure, and how we can change this scenario with the solution that I present, that is the Monitoria device. And also talk about the Janica project, that is a multidisciplinary project of follow-up of patients with chronic heart failure. And then talk a little bit about the future work that this actual episteme of technology and artificial intelligence can bring us. Please proceed. I have no disclosures to present. Proceed, please. Okay, so as I said, proceed, please, for the next slide. As I said, cardiovascular diseases are the major causes of hospital admissions as well as mortality worldwide. You may proceed to the next slide, please. And this is because the population is being treated very well for the last decades. So they live longer and without a lot of diseases, but the chronic diseases may be more prevalent, as you understand. And one of these chronic diseases is actually the heart failure. So we have more patients with heart failure, and this heart failure includes a lot of morbidity to the person who carries the heart failure, and also to their families, their relatives. And this is a disease with a lot of consumption of health resources. So decades of research in the heart failure does not translate as much in the daily life practice. What I see at my clinic here in the hospital of heart failure is that the patients doesn't benefit so much from the research that is being done in the studies, in the clinical trials, etc. So, and this is why because the patients that we follow in the practice are not the same as the patients that are studied in the clinical trials. So we have to know better the patients that we follow to improve the treatment of the heart failure. And we have also to take advantage of technology and artificial intelligence as well. Next slide, please. Next slide, please. Sorry. Hello? Yeah, thank you. Next one, please. So, heart failure. Heart failure actually is a multifactorial chronic syndrome that is afflicting a lot of a big proportion of people worldwide. And its incidence, it's stabilizing, as we understand, but its prevalence, as I told before, is increasing. And this carries a lot of burden, not only in terms of morbidity, but also in terms of economic and financial terms. So what I have to mention here, what I want to mention here is that despite significant innovation in therapy, either by pharma or by devices, and in development of monitoring protocols and whatever about that, patients are still dying a lot. They are still becoming hospitalized, recurrently hospitalized. So something is wrong and we have to know what. Please proceed to the next slide. The next slide, yeah, thank you. So here in Portugal, in parallel to the rest of the world, we have a lot of prevalence of heart failure. And the admissions in the hospital are very high nowadays, as well as the mortality rates near 15%. And this mortality rate is bigger if the patient had more than one previous admission. So the more admissions the patients have, the more the mortality they have as well. So what we have to do here, what seems to be needed to do is to improve the management of the patients with chronic heart failure at home in the ambulatory setting. Next slide, please. So the question I may pose is if actually we are monitoring these patients well or properly on ambulatory, specifically if we are predicting the right things, because nowadays we are more reactive rather than predictive, and we have to change this paradigm. We have to move from being reactive to the decompensations of the patients to a predictive scenario. We have to predict the factors that conduct to the decompensation of the heart failure. And so the next slide, please. Nowadays, we know pretty much the major factors that are known to be decompensated in patients that become admitted to the hospital. These are the most relevant factors, like high heart rate in resting, the low heart rate variability, the rise in the ventricular filling pressure, and the arrhythmias, either atrial or ventricular arrhythmias, the high respiratory rate, and of course, the pulmonary congestion. Of course, that we see that the heart failure is a big issue. Sorry? Yeah, thank you. We see that nowadays heart failure is still a big issue, and it's not only the pulmonary congestion that we are used to see in the patients that are admitted. We have also other factors that we have to face in the monitoring ways that we use in the ambulatory. So next slide, please. We think that we must improve technology and also the models to predict these factors. So if we can predict these factors, we can treat patients before they decompensate. Next slide, please. Actually, it has been theorized that remote monitoring can be used to improve the heart failure management. And this can be done in three ways, either by the patient itself, by the healthcare professional, or by a device. We are very, very used to have healthcare professional monitoring the patients, usually nurses, not so much the doctors, and as well the patient itself. But the better is the device. Why? Why is it that so? Because the patients, specifically the patients that are followed by the internists, they are very old. They are very old. They have a lot of complications, including cognitive complications because of the low perfusion of the brain in the context of the heart failure. And we must have a way to monitor the patient without the need of the patient being doing something for his own monitoring. So we think that the device monitoring manner would be the best option to monitor these patients at home. Next slide, please. So what's the solution? The solution is actually a device like this device that we are researching on. Next 2 slides, please. Next one, please. Yes, the device that is called Monitoria. Monitoria, why? Monitoria is an acronym of monitoring non-invasively the heart failure in ambulatory to improve mortality rates. This device is embedded on a valve on the chest that has to be adjustable to both to the males and the female, and it must be very adjustable in order to keep in position the sensors that I'm going to talk about in the next slides. Can you move to the next slide, please? Yes, these are the sensors that we include in our device. We have sensors to measure the transthoracic impedance. We have sensors for electrocardiographic data, also to measure the right atrial pressure, the blood pressure, the peripheral oxygen saturation, and as well a chemical sensor to measure the sodium content in the sweat. Next slide, please. This scheme shows us the sensors that I told you in the previous slide. So as you can see here, we have these few sensors that must capture the most significant factors that are known to be predictive of the decompensations of heart failure. So with this type of monitoring, we will predict not only the congestion using the bioimpedance sensors, but also other factors like the arrhythmias, like the heart rate variability, or the alterations in the sodium content that will predict in about a week the compensations of the heart failure. So if we see these variations, we can call the patient earlier to a consultation at the daycare hospital, and we can treat or adjust the therapeutics of that patient, and then he will not be decompensated at all because he's stable at home, he doesn't feel nothing. We just see these alterations in these sensors, and then we prevent the decompensation to come. Next slide, please. This is a resume of the sensors that we include in this device. So the transthoracic impedance uses ACG electrodes, dry ECG electrodes that are placed on the chest, on the right side of the chest, and also on the back. Using the sensors this way, we can have less confusion, less confounding factors. So actually the water or the impedance that we analyze will be actually the impedance of the lung and not from the other tissues of the chest. The ACG data will use 9 electrodes, a set of 9 electrodes, because we need not only to see to check the heart rate and the heart rate variability, but also minimal changes as myocardial ischemia or other teeny changes that may predict the compensations in the future. Next slide, please. Right atrial pressure. We'll use the near-infrared spectroscopy technique. And this is quite innovative because until now we are used to see this in the monitors of the clinics and of the hospitals, and not on wearable mode. So now we are trying to translate this technology to a wearable mode on a chest burst. The photoplethysmography to measure the blood pressure is quite known as well, and will be the less innovative here, but will be very needed to be used for not only for the analysis of the bioimpedance, but also to correlate with the data of the electrocardiogram as well. Next slide, please. The peripheral oxygen saturation sensor will not use a sensor in the finger, that is the usual one, but a sensor in the chest. This will be the best way to monitor the peripheral oxygen saturation while being less invasive to the patient. The skin sodium content is the very ultimate innovation in this monitor, because we will measure the sodium each day during the night in the skin of the patient, and this will correlate with the quantity of sodium ingested by the patient. So with this, we can adjust the doses of the diuretics, for instance, and we can also check if the patient is taking too much sodium in the diet, or lots of water over than the quantity that we are used to counsel to the patient. So this parameter is innovative, and we think that will be quite important in the management of these patients at home and in the ambulatory setting. Next slide, please. So this is the operating mode of our device. The patient uses the vest. The vest is to be used 24 hours a day. It must be taken off to take bath, but this period can't be longer than 30 minutes. If it is longer than 30 minutes, the sensors will send an alarm to the patient, so he must wear the vest again. The patient uses this vest 24 hours a day. Then the data are collected and recorded transiently in the smartphone that must accompany the vest. This data is recorded transiently in the device of the patient, and then it will be transferred automatically to a cloud server solution, which will gonna record it permanently. And this cloud server solution as well, we're gonna send the data to the physician in charge. The physician can access the data of all the patients that are linked to him and that are using this type of monitoring. And the doctor may assess this data actively to check if the patient is okay, or passively. This is the physician receives some alerts in his laptop or in his phone saying that some patient of him is having some wrong signal of some of these sensors. The patient will see which sensor is alerting him, And according to the alert that he is receiving, you're gonna call to the patient, asking the patient if he's complaining with something. And according to the symptoms or signals of the patient, the doctor may decide if you're gonna call the patient earlier for an appointment, or if you're gonna change the medication, or etc. In parallel to this reference to the attending physician, this device in the future will have the potential to send as well alerts to the national emergency team, especially if the ECG data, for instance, shows some signs of myocardial ischemia or of ventricular arrhythmias that will going to be potentially lethal. In these cases, it will, in parallel to the doctor, to the attending physician, it will also send signals to the national emergency team. Next slide, please. This device will be included as well in a major project, in a bigger project that is called the GENICA project. This GENICA project is a multidisciplinary project, which includes not only internists, but also cardiologists, nurses, psychologists, social assistants, and also physiotherapists. The objective here is to manage all of the aspects of the patients carrying heart failure, chronic heart failure, because it is not only important to treat well the heart failure, but also to check if the patient has enough money, for instance, to buy the medicines, or if the patient has the family support or the background support necessary to take care of the medication, for instance, or to check if the patient is not too much depressive. We have to check all of these parameters, all of these settings in order to improve the control of the heart failure at home. Next slide, please. So, with this type of follow-up, we want to show, I can tell you that I have some preliminary data that shows that with this type of follow-up, and I may say that here, the very ultimate thing, the very innovative thing is that the monitoring is done by doctors and not by nurses, as it is usual to do. The doctors call to the patients actively to check if the patients are doing well, and the patients have the freedom to call whenever they want to the doctors, to their doctors, asking for some recipes or prescriptions, clarifying some doubts about the disease, about the prescriptions, about the symptoms or the signals that may come. And this investigation, this preliminary data shows us that we can reduce the mortality rates and as well the rate of the hospitalizations. As you may remember, I start my presentation by saying that one biggest problem here is the number of the previous hospitalizations, and with this type of follow-up, we can reduce it by 35 to 40%. So this is huge. And this is just the follow-up without the Monitoria device, because right now, the Monitoria is being developed. We have a team, an international team, with the researchers from Italy, from Qatar, and from Portugal. And we are still working on it. We don't have the device yet. And even not having the device, using just this type of follow-up, we can reduce these mortality rates and hospital admission rates. So we think that when we have the device, the improvement will be will be greater. So future work, as you may pass the next slide, please. The future work will include, of course, this device, not only to monitor the patients at home and predict the decompensating factors, but also to include some possibility of therapeutics. The objective here is to include a subcutaneous way to administer diuretics, mainly furosemide, and as well morphine in the future. The other thing in the future work is to improve the algorithms. We have the Scientex algorithm that is being constructed with the variables collected by this follow-up program. It is almost ending. We're going to end the next year, so we're going to have data that will going to enable us to construct the algorithm to predict in parallel to the Monitoria, to predict better which patients must be observed in a short time, or which patients must be observed in a month or 3 months, and schedule better our consultations. Next slide, please. So thanks for your time. It was a pleasure to be here presenting this little research of mine and my center. If you have any questions, please proceed.
Okay, thank you so much, Dr. Carla Martins. It's a great pleasure to have you here. That was a very excellent presentation. We thank you once again.